from a possible acute appendicitis is an art and a skill that we want to grow. Balancing that with the fact that we also want to be judicious and evidence-based in our use of both imaging and lab modalities. So joining us today are Dr. Lesli Taylor, Dr. Brad Feltis, and Dr. Michael Allshouse. So Dr. Taylor, I'll go for her first, came to us in the year of 2005. So she has been with us 16 years. For many of those years, she was the solo pediatric surgeon for our region. And over the course of her tenure here, she has given innumerable lectures, and many of them were surrounding appendicitis, ruptured appendicitis, and belly pain in children. Second, we have Dr. Brad Feltis, who joined us in the summer of 2020. He came to us from Minnesota. He is a renowned fetal surgeon and has specialized in both fetal surgery and newborn anomalies. And we are so grateful to have him as part of our team here at Niswonger. And then last, but certainly never least, is Michael Allshouse, who also came to us in the summer of 2020. Mike is a character, to say the least. He is an accomplished surgeon, both in pediatric trauma as well as anal rectal malformations. He has a special heart for children with special needs. More than that, he is a funny guy. The only person funnier than him is Brad Feltis, but you got to wait for it with Brad. So we really appreciate them lending us their expertise in the surgical care of abdominal pain, and we are thrilled to turn the mic over to them and learn a little bit about appendicitis in 2021.
Thank you, Dr. Chambers. Let's see. Pictures. All right, I'm assuming that my screen is now being shared.
That's good.
Okay, good. Thank you. Yeah, so pediatric appendicitis. What's new, right? How many more billions of times are we going to talk about pediatric appendicitis? The most common surgical problem we have in kids. The better part of 100,000 kids a year get their appendix taken out. But beforehand, you guys know that of pediatric ED visits, abdominal pain is usually third, right after respiratory complaints and trauma. And so this is a continually evolving field. It's something that Mike and I and Leslie have a lot of experience in. And believe it or not, there's quite a bit of new information about helping us to manage these kids. Lots of things have changed just in the last 5 years, and certainly in the last 10 years, as appendicitis has gone from being an overnight emergency to something that we generally tackle within the first 24 hours of presentation now. So both management, diagnosis, surgical options have all changed. And so we're gonna touch on a lot of those today. This isn't going to be a traditional didactic lecture. We're going to have this mostly case-based, and Mike and I and Leslie are going to kind of rotate, do a round robin, and raise your hand or notify the moderator in the chat room if you want to ask a question in real time. Again, we're going to hopefully discuss several cases. These are cases that we've seen in the last several months here, cases that either presented here or have been referred in. And so we think it's going to be an enjoyable hour. And just briefly, I know Dr. Chambers already introduced. Most of you know Dr. Taylor. She trained at the world famous Children's Hospital of Philadelphia. And then she was in at UNC for the better part of 15 years, and she's been here for about 15 years, practicing on her own. Now, when I'm on call for a week, I'm really looking forward to Monday morning coming around because I'm exhausted and tired and a little cranky. Leslie was on call for 15 years. And so every time I finish up a week's worth of call, I think to myself, oh my goodness, I would have never been able to do that. But we're excited that we're able to expand our department last year with the addition of the infamous Dr. Allshouse, who claim to fame is that he was a Naval Academy graduate, And then actually he was an adult surgeon in the Navy for several years prior to training in pediatric surgery. He joins us from a very busy practice in Fresno, and he relocated last year along with me. I was at a busy practice in Minneapolis, and I was recruited out here with Dr. Allshouse last summer, and I've been really excited to be here. So with that, I'm going to turn the microphone over to Dr. Allshouse, as he's going to give us our first case presentation.
Oh, there you go. So these slides look much better than the ones that I sent to Sheila. She's very helpful. So welcome, everybody. Some of the people on this call are old friends, and some people are people that I've just met for the first time, but we're here today to share information and the things that we've learned over the years. And of course, we have a lot of concentrated experience. When Brad divvied up the roles in this, was assigned to try to present some cases that were thought to be possible appendicitis that turned out not to be, just to show you how some of the pitfalls in diagnosis. And I included a couple of slides in this presentation with a reference in the end that we'll talk about a thing that's equally important, and that's how to properly and safely image kids when you have abdominal pain. Let's look. Belly pain in a kid, it's kind of like a Christmas package under the tree, you know, a Christmas present. You're not really sure what's on the inside, and we get to open the package sometimes, but you guys just have to sit there and try to guess what's inside and what it would be. So the first case we're talking about was a young lady who was transferred to the Niswonger ED from Bristol, and she had a sudden onset of lower abdominal pain that literally awakened her from sleep at 5 a.m. She specifically knew the time, had some nausea and vomiting noted. Now, her history is complex because she has chronic abdominal pain, carries a diagnosis of irritable bowel syndrome, cyclic vomiting, and polycystic ovary syndrome, along with chronic constipation. So this is not crystal clear from the start. Her white count and her CRP were both normal, and she had a non-diagnostic ultrasound examination, which also specifically didn't say anything about fluid in the pelvis. So the next step was that she got a CT scan of her abdomen and pelvis. And what was seen on the CT scan, if you can show me the next slide, it's kind of hard to tell because my cursor, can you guys see my cursor? But in her appendix is almost vertically hanging off of the cecum, and was a little enlarged, but there's no surrounding fat stranding, no calcified appendicolith, and the radiologist read this as possible early acute appendicitis. So when we got her to the hospital, I opted to admit her and observe her, and the next morning her pain was much better and had not progressed, so we continued to observe her. You want to do another case, Brad, or do you want me to do my second case right now too?
Why don't we go to, you know, I'll tell you what, Leslie, I'm going to change your, let me present my first case, Michael, and then
okay.
we'll go, and then, because I think mine will follow this one nicely, and then we'll go to Dr. Taylor, okay?
Good.
Okay, so a couple, when we're talking about abdominal pain in kids, we need to remember a couple specific things that can throw us off, and we see these a few times a year. So abdominal pain and nausea in the diagnosis of streptococcal pharyngitis in boys. This was a fairly recent study, 5,700 children aged 3 to 15 that showed up with fever and abdominal pain. 10% of boys and 3% of girls end up having the diagnosis of strep throat. So always think of possible strep throat, especially in boys with abdominal pain and fever. And always remember that lobar pneumonia needs to be in the pediatric and adult differential diagnosis for acute abdominal pain. This is just from a few years ago as well. This was 258 consecutive children with pneumonia, and acute abdominal pain was the main presenting symptom in almost 10% of them. So always remember strep throat and pneumonia in your differential diagnosis for pediatric abdominal pain. And with that, I'm going to present my first case. This is a 9-year-old male that we saw with 12 hours of pain and emesis. On questioning, he said he woke up and it was hurting around his belly button. He wasn't hungry for breakfast, which was unusual for him. The pain quickly migrated to the right lower quadrant and became more pronounced. He then had quite a few episodes of vomiting that was non-bilious. The family called the nurse line and they were told to come to our emergency department. When I asked him how the ride over was, he said he felt every single bump. So essentially this kid took page 1 out of the pediatric surgery textbook on classic presentation for acute appendicitis. He essentially had everything that was classic about, again, the traditional presentation. Again, he's a pre-adolescent male, no significant medical history, just a bit febrile. He's a thin 8-year-old. Exam was significant for focal point tenderness over McBurney's point. Remember, Robsting sign is when you press in on the left lower quadrant, you get tenderness on the right. He didn't have any hernia. You always need to make sure that you do a GU exam, check for hernia. Extremities were normal. I asked him to get out of bed and hop up and down for me, and he refused, which is a positive hop sign in my mind. So again, so the kid's got so he's a prepubertal, thin male with a classic history and a classic exam for appendicitis. We did get some studies. His white count was normal, which isn't that unusual, but it was left shifted, and his CRP was elevated. I've found the CRP to be, they're both acute phase reactants. I found the CRP to be an earlier acute phase reactant. Combining the two gives us a little bit more sensitivity in diagnosing inflammation. So here we have a kid with classic story for acute appendicitis, classic history for acute appendicitis, and he's got some laboratory markers that are suggestive of acute appendicitis. So what do we do now? So this is where the discussion is. What's the right thing to do now? What I would ask you to do is to call your pediatric surgeon with this information. Because if you have a child with a classic history and a classic exam, especially if the child is pre-adolescent, I have all the information that I need on this child. Because if we get an ultrasound and the ultrasound's non-visualized, it doesn't change my, which is a possibility. It doesn't change. It doesn't change anything about my diagnosis. And this is not a kid. Dr. Allshouse is going to talk a little bit about some of the risks of CT. This is not a kid that I would CT. So this is a kid that I have enough information right now to say that this child has acute appendicitis. Again, it's not wrong to order an ultrasound for an imaging test next, but we would prefer to discuss a child like this with you. So I wanted to show you this child. Let's see, I don't know if I wanted to. Okay, for 2 reasons. I wanted to show you this child, both to demonstrate that there's a population of children that likely don't need any imaging. We can just do traditional physical exam and some laboratory markers, and also to talk about something that's relatively new, which is the non-operative management of simple appendicitis. Now, we would have to get an ultrasound if we wanted to recommend non-operative management. I'll come back to that in a minute. So non-operative management of appendicitis has been a thing for the last few years in kids. If their symptoms are less than 48 hours, if their appendix is less than 1.1 centimeter, there's no appendicolith, there's no abscess, there's no phlegmon, and if the white count is less than 18,000, those kids are eligible for non-operative management. And here's what non-operative management is: IV antibiotics, pain meds, serial exams, NPO for 12 hours in the hospital, and then advance the diet is tolerated, discharge home with a week's worth of oral antibiotics. So if you do that, so this is a recent review of 10 articles describing 413 children with non-operative management. There was one randomized controlled trial. Importantly, non-operative management, you can see the bottom line, was effective in 97% of the children. So for that group of children, 97% of them can be effectively managed non-operatively. The initial, but the kids stay in the hospital about a half a day longer than kids treated with appendectomy. And so this is a relatively new phenomenon. So we don't have a lot of long-term follow-up, but this report, this meta-analysis showed that at 2 years, 79, at average of 2 years, about 80% of the children still had their appendix. Now, the longest report out there is 4 years old, and about 60% of kids have had their appendix. So there seemed to be about a 10% per year attrition rate, or a 10% per year progression to either recurrent appendicitis or getting your appendix out. Again, complications were similar. So this is interesting. The pediatricians and the surgeons look at this data a little bit differently. Now, we both agreed that non-operative management is safe. It's effective as the initial treatment, 97% that meet those criteria. And the rate of recurrent appendectomy at 2 years is 20%. So the final statement from the group of pediatricians: although some surgeons may feel this demonstrates inferiority to appendectomy, a 2-year efficacy of 82% still equates to 4 out of 5 children not having had surgery in general anesthesia. So here's how we do simple appendicitis now. It's called single incision transumbilical appendectomy. We put a port in through the belly button. We fish the appendix out through the belly button. We divide the vascular supply and we secure it from the bowel. We tie it. So this is essentially just doing an open or a laparoscopic assisted transumbilical appendectomy. That's what the belly button looks like at the end. It's generally a scarless procedure, and the kids go home a few hours later. So I'm not a fan of non-operative management. We mention it to all the families, but I think with a 10%, what looks to be a 10% annual incidence of the appendicitis coming back, I'm guessing that at 10-year follow-up, we're going to see that a majority of these patients have progressed to appendectomy. That seems to be the trend, but we're still in the initial bolus of this information. And again, when you have a surgery, this transumbilical laparoscopic assisted appendectomy takes us a half an hour to do. The kids go home a few hours later, and then they're, I let them go back to full activities the following day. I've had kids play football the next day after having the surgery done. So my bias is towards for the kids with early appendicitis. So 2 things from this case that I wanted to present. Number one, for something that's this straightforward, I often don't request any further imaging. So if you call me with the history and physical exam that this kid had, I'm going to say, yeah, we don't need to image that kid. Just go ahead and send him over and we'll get his appendix taken out. And then number 2, for the kids that meet the criteria, we are discussing non-operative management. And I've had patients choose non-operative management, people who are just risk averse and would rather not have surgery, and that's fine. But we are discussing non-operative management with people now. Any questions before we move on to the next case? We can have a Q&A session at the
Yeah,
end.
can you unmute me? Who should manage it if it is managed non-operatively? And my vote would be that a surgeon still needs to be involved if it's going to be managed non-operatively.
Yeah, that's correct. That's a great point. Yeah, the studies were all with the surgeons making the surgeons deciding when the peritoneal signs had resolved, and the surgeons being the ones responsible for following the kids and deciding if they were successfully managed. Yeah, so this is the surgical team does manage these patients if they take a non-operative management route.
Hey,
Okay.
this is, this is Cassie Hudson. I don't think you all can see me, but I'm a pediatrician up in Bristol. And I'm really interested about the imaging. So now kind of our workflow is that, you know, if we have a kid in the office that we suspect appendicitis, we just send them over to the ER. So would you all prefer for us to call you or send them down to No Swanger? It's not that big of a drive or a burden to be evaluated in the ER, and then the ER doc give you guys a call about imaging or not?
Yeah, so we work with Dr. Brown and his team, and so we're always happy to, I think it's Dr. Brown and his team are so great at triaging the calls, and actually they're much easier to get a hold of than usually the surgeons. If you have a specific question for the pediatric surgeon, we're always happy to talk to you. But if it's just if it's a kid that you think has appendicitis and you want to refer them in, I think Seth, are you on the call? Do you want to speak to that? But I think I'd be happy with them talking to you and your team.
I don't know if Seth is on, but I can just say that I think the work that you all did around smoothing it out and the I'm an emergency medicine physician when I'm not chief medical officering and trying to wrangle in Mike Allshouse, and the responsiveness of the surgical team is awesome. And so if you ever have a patient that you feel would benefit from a surgical consult, send them our way.
And I want to second that. I have a 1 bullet slide later on in my slides, which I'm just going to jump ahead. The strongest predictor of CT imaging for pediatric patients with appendicitis is the type of hospital to which they present. And if you send a kid to an adult ER, they're going to get a CT scan a lot of times that they don't need. And Brad just showed you how nice and safe this operation is. I'm going to show you some data that would suggest to me that having your appendix out is safer than having a CT scan for the child, if that's what it comes to. The other part, which I would like Brad to discuss, because he's an expert on this, is the non-operative management also entails a week of antibiotics, and we're currently in a new phase of antibiotic stewardship. And in fact, is a week of antibiotics safer than a simple operation for that? And how does that factor in?
I have one comment. If you are going to call the surgeon or Dr. Brown, go through MD Link. They have so many resources. If it ends up the child needs to be admitted, they'll check the census, they'll get the bed for you, they'll take all the registration information. They can do much more than any of us could do. So always call through MD Link.
Dr. Allshouse brought up I think a really good point with not only with antibiotic stewardship, but with microbiome stewardship, right? Literally every month that comes out, there's all sorts of new information about what a healthy microbiome means to digest, not just digestive health, but anti-inflammatory health, et cetera, et cetera. And obviously the broad spectrum antibiotics are just devastating to the microbiome. So we still don't know what the morbidity associated with, we know some of it. We know about the diarrhea morbidity and the malabsorption morbidity. But this also gives me a chance to launch into one of my key soapbox issues. If you're going to prescribe someone a broad spectrum antibiotic, make sure that they're taking a probiotic simultaneously. It logarithmically reduces both antibiotic associated diarrhea, mostly in kids antibiotic associated diarrhea, but some C. difficile associated diarrhea as well, which, as you know, isn't a problem in the young kids, but can start to be a problem in the adults. So that's actually a Cochrane B+ recommendation for probiotic use when you're using a broad spectrum antibiotic. but yeah, that's another reason people just assume that a football score worth of antibiotics, is kind of a benign treatment. But I would disagree with that. So there's a number of reasons that the surgical team isn't a fan of non-operative management, and it's not just because we're surgeons and like to operate. It's because we think it's a safe and easy and definitive operation that kids recover from quickly. Why don't we move on, because Dr. Taylor is going to talk about what happens when we miss appendicitis diagnosis early on, and it turns out to be a mess. Leslie, you want to present?
Yes, we're getting the slides up right now.
Can you say that?
Yes.
So when we have a child that's very stoic or the family is not very attentive, they can actually rupture at home and sit at home for days, or get taken to multiple doctors and get discharged with the wrong diagnosis. And I call that missed ruptured appendicitis, where they've actually formed an abscess. And we'll focus on the type of abscess that the interventional radiologist can put a drain in. Sometimes it's such a mess in there, so inflamed, that it's better to drain it and cool everything down and come back later. And I have nothing to disclose. I will mention some antibiotics, but I have no association. So this was an 11-year-old girl with missed ruptured appendicitis who required drainage, and she actually needed to have it through her buttock. So on Friday morning, she had some abdominal pain and vomiting. As we've already mentioned, that could be many, many things. Saturday, she still had pain, went to urgent care in Grundy, and was sent home as a virus. Then Sunday, she had diarrhea. And the diarrhea can occur because the inflammation in the pelvis is irritating the sigmoid, and the children have loose stools. And years ago, I was fooled by that myself. And it can be very difficult to sort out, well, is this gastroenteritis or is this diarrhea related to a pelvic abscess? Well, she still wasn't doing well on Monday, stayed home from school, still in pain on Tuesday, went to an urgent care on Wednesday, and then was off and on better. And as the child walls it off, they can actually seem better, and they eat and they, don't complain as much. But then on Friday, now a week out, at 3 a.m., her pain was worse. I don't know if this is the first time the family notified the pediatrician, but they sent them to Buchanan General and got a CT scan. And as we've already mentioned, we understand that getting an ultrasound at some of the smaller outlying hospitals, you don't have staff in the hospital 24 hours a day, and you have a CT scan, and that's partly why you do that CT scan. And it showed a pelvic abscess, and she came down to Johnson City Medical Center and had a percutaneous drain put in by the interventional radiologist. But the child stays on the surgical service, and we manage every part of this, including the IV antibiotics. So this is her pelvic abscess, and here, and the radiologist has a difficult time sometimes figuring out, well, how am I going to get to that? And you can see by that yellow arrow, this very sensitive computer here, see the white drain sticking out on the lower picture. He actually went through the buttock because that avoided bowel loops, all kinds of bladder maybe, all kinds of other things that could be injured. So and they always send it for culture. She grew up hand-sensitive E. coli and Streptococcus constellatus, which was resistant to clindamyces and but sensitive to everything else. Now, this was about 3 years ago, and ideally you would look for a resolved abscess cavity with an ultrasound. I can't remember why we got a CT scan in her, but we did get follow-up imaging to be sure the cavity was resolved, and then we removed the drain, and she was sent home on oral amoxicillin. And there's some debate among pediatric surgeons, but I was trained back in 1988 when I was doing my pediatric fellowship to do what's called an interval appendectomy. We don't want to leave that appendix in there to cause trouble again. We already know that it's done it once. And so let the swelling, let the inflammation go down and bring them back and do an interval appendectomy. Now, this was another child, a 6-year-old, that went to Holston Valley and was sent home as a virus, and then went to Indian Path and had an ultrasound there, which was read as normal appendix. And I would just emphasize that the vast majority of the time, you either see an inflamed appendix or a non-vis of the appendix. Seeing a normal appendix in a 6-year-old is pretty hard, actually, even if they're thin. And so probably that was a non-vis, or you can't just call it normal unless you actually see a normal appendix. The other thing I would point out is 5 years ago, BALA did not exist. So Holston Valley was Wellmont, and Indian Path was Mountain States Health Alliance. And she got sent home from Indian Path. And then the third day she tries to get care, she comes to Johnson City Medical Center, and somehow they're reading constipation on an ultrasound, which is really not, it's hard to see constipation on an ultrasound, but that's what the reading was. And then you notice that 10 days go by, and she now has a fever of 104, finally comes in, gets a CT scan, and shows not only a pelvic abscess, but a liver, an intrahepatic liver abscess. And I would point out that the fact that the child went to 3 different providers, it increased the fact of the delay in diagnosis, because the continuity is just totally lost, particularly because we were in 2 different healthcare systems at that time. And this is what she looked like. Fortunately, this was amenable to percutaneous drainage. And you can see the smaller liver abscess, I mean, the very large liver abscess that actually has an air fluid level in there, and then the smaller pelvic abscess there. So they put a drain in, I can't remember, she probably had 2 drains, and got over a cup of purulent fluid. That grew aeruginosis, E. coli, and Bacteroides. She had IV antibiotics in the hospital. For something as complicated as this, I got our pediatric ID involved, Dr. Demetrio Macchiola. He sent her home with a PICC line, in contrast to the first girl that was able to go home with oral antibiotics. He sent her home on ceftriaxone and Flagyl. And then we got an ultrasound to be sure that there was no residual abscess before we pulled the PICC line. Again, the very complicated situation with the liver being involved. And we waited about 6 weeks and brought her back for an interval appendectomy, and found that the cecum was actually sitting pretty high up near the liver. And another comment along these lines, when the ultrasound is done, it's not a pelvic ultrasound. You have to specify appendiceal ultrasound. And Dr. Neal, our pediatric radiologist, always makes our techs go all the way up to the liver, all the way down in the pelvis along the right side, because several times I've seen the cecum sitting right up by the liver, and they may or may not have malrotation. It's just a high sitting cecum. So just to review that, if it's a well-formed abscess, it's localized, then we can diagnose it by ultrasound, or if they end up getting a CT. But you need the CT, or the choice of the interventional radiologist is to have the CT scan for drainage. Now, if they have a fecalith, then they're not a candidate for drainage, and you just go in and bite the bullet. And rarely you end up having to do an open appendectomy, because it's just such an inflamed mess in there, you can't safely see what you need to see with the laparoscope. And I'll just show you a few other images of this. So again, this is a very localized abscess here. And go back up, it's another child. And this one is very easy. You see the yellow line actually may be the, I don't have the drain view of this one, but as long as the radiologist has a window, there's no bowel loops in the way, and they can get that in if it's big enough, and if they have a window through the abdominal wall. This was another patient with an appendiceal abscess on presentation. That big gassy area, that's not the abscess. But on the CT scan, you can see the abscess was, I think that's probably just some bowel loops that were dilated. The CT scan shows the abscess in the pelvis. And this one had a very, very large abscess with an air fluid level. And that doesn't mean that that air may be from the appendix, but sometimes it's gas forming organisms. And again, there's an easy window in this thin child for the radiologist just to put the drain right through the abdominal wall. Now, I want to close by just contrasting the times when we cannot have the radiologist do it. If the bowel loops are in the way, if there's a fecalith, then we go ahead and do the open, or laparoscopically first. And you can see that this is a pretty gnarly appendix that we got out of that mess. And here's another one. This was a 13-year-old boy, had extensive peritoneal soiling after a missed ruptured appendix. And we deemed that he was not a candidate for percutaneous drainage. He didn't have a well-formed abscess. And this is the base of his appendix. Sorry. And the reason he could, sorry, this was why he could not have a percutaneous drain. You can see that he just has diffuse soilage all throughout his abdomen. He ruptured and it went everywhere. And this is actually looking up into his left upper quadrant. The liver's at the bottom here, and then he has all these nasty, strandy pus collections up there. And that is what the tip of his appendix looked like. And you could see from the image that the picture that Dr. Feltis showed, a normal appendix doesn't look anything like this. It still has some continuity to it. And so this was a very, very ruptured appendix. And this was a case that I will never forget. This is a 17-year-old young man who was a star athlete. Not only that, he was his high school's athlete of the year. And he had a delay in diagnosis. And you can see that although a drain, they might have been able to get some of that liquid in the bottom there, it really wouldn't have solved the problem. And so he did end up, I was able to do this laparoscopically, even though you can see again that the inflammation makes it's almost impossible to see what the anatomy is in there. Good news, he was not a girl, and we didn't have to worry about injuring a fallopian tube or an ovary. Unfortunately, he had a complication of this. He had moved on to the adult side. 2 years later, he had to have a bowel obstruction, which was managed by one of our general surgeons. And I'll turn it back to Brad.
Thanks, Leslie. Yeah, perforated appendicitis can be tricky. We just, I operated on a little girl over the weekend, last weekend, and she had 4 days of pain. And the, you know, her pain started on Wednesday morning. She just felt like she had the stomach flu when she got up, and she started throwing up, and the mom just thought it was a stomach flu. It looked just like the stomach flu. She's anorectic, and she felt okay the next day. And again, mom was just certain it was a stomach flu. And then Friday night, she started getting worse, and they came into the ED. And then she was diagnosed with appendicitis, which was found to be perforated on exam. So it can be a very tricky diagnosis. This mom was beating herself up because she felt really bad. Now, what we reassure them, all of these kids get all the way back to better, but perforated appendicitis is one of our most frustrating diagnoses for us and for the families. Our average patient is here 6+ days with perforated appendicitis. Once or twice a month, we'll have a kid here for more than 10 days with perforated appendicitis. Last September, we had a child here for 21 days with perforated appendicitis. They had their operation, and then they developed an abscess after operation, which can happen in 10% of kids with perforated appendicitis. But these kids are miserable. You know, they have an ileus, they're not eating, they're distended, they have colicky abdominal pain, they're febrile. So it's a crummy diagnosis. Thank you, Leslie, for that overview. Michael, I think I'm going to turn it back over to you for the rest of your slides before I present my final case, okay?
All right, cool. I've had the misfortune, Brad, working in the Central Valley, California, where we had a lot of indigent population and poor care, to have 3 children die from perforated appendicitis.
Oh my goodness.
Complications of sepsis and septic, inflammatory response syndrome. It's not common, but the other thing is that in many large databases of perforated appendicitis, the children have been to a healthcare provider an average of 3.4 times before the diagnosis is made. So it isn't always easy. So let me go to the next slide then. I had another little boy that I presented here who came to the Niswonger ER with an autistic spectrum disorder. So I thought I would put this in there because the diagnosis can be even more challenging if the child is unable to give you a good history. Very high fever, normal white count, but his CRP was over 100. He had a very equivocal exam, which was difficult because of his behavioral challenges, had a normal ultrasound, but a CT scan was ordered, which showed a normal appendix, but some mesenteric lymph nodes. I didn't copy that in there because I didn't think it was helpful. So what I wanted to tie into this, though, is just to help you look at some of the data that's been published about what's the best way to image these. Can you have the next slide, please? So the conundrum we have in children is extremes of age. What I put by gender is, as Leslie already alluded to, in some cases, the presence of female organs and reproductive age adolescent girls can make things more challenging, but also important for considering the imaging. The availability, quality ultrasound. And I would just stop and say I hear that all the time from places that say, well, we can't get an ultrasound, so we get a CT. And again, I would circle back to what Brad said. We would almost rather you call us and let us help you make the decision than to go ahead and order a CT scan if it's equivocal. There are some places that refuse to do CTs without IV contrast on kids because they don't have an IV or their protocol says they have to have a creatinine. That doesn't make sense when you're doing acute CT imaging for trauma or acute abdomens. You don't worry about contrast. And in fact, one of the published papers that I put in your syllabus at the end is from a Japanese study, a Journal of Radiation Research, that says estimation of the effects of medical diagnostic radiation imaging and DNA damage showed that there's some increased risk of single and double strand DNA breakage if IV contrast is used. Nobody really knows why that is, but it's interesting. Parental pressure, sometimes the parents come in and demand imaging and push us to, my kid needs a CT scan. A CT is definitely faster and more reliable. And interestingly, we bear some of the responsibility for this because there are hospitals around the country where the surgeons refuse to come in and see people unless they have a CT proven appendicitis. So some of this data is old, but it's the best I could find that would make the point. And so in 2006, there were 6 million CT scans performed in children. That's probably pretty consistent across the board, although it's decreased a little bit recently because of the gentle imaging movement. And the CT of the abdomen in a 1-year-old child results in a lifetime risk of mortality of 1 in 1,000. That's not my data. That's what the ALERA data shows. And ALERA is an acronym put out as low as reasonably achievable. And how does CT present risk to children? Well, heritable effects, embryo-fetal effects, and carcinogenesis. Next slide. So there's effect on DNA, a direct hit effect. You can actually look at T cells circulating and study and see these things on kids after and adults after they've had DNA imaging. There was a Swedish hemangioma study that showed there were cognitive defects when children had lots of CT imaging. And what we know now, based on Hiroshima data, and also on a study that was just published in JAMA Surgery recently, is that children between the ages of 0 and 15 years of age are much more likely to have effects related to hematologic malignancies than are adults who have CT scan. Next slide. So here's a little graph I put together to show you what happens between pediatric trauma centers and non-hospital trauma centers when you get different types of CT scan. This data is available in the trauma world. So if you get, and the DLP in there stands for dose length product, which is a standard radiologic mechanism to measure a gray exposure to people. So if you go to an adult hospital and get a head CT, you're going to be about the same as in a pediatric trauma center. But look at the difference between the CT of the chest and the abdomen. The gentle imaging done in pediatric centers where they know about the dose reduction results in a substantial decrease in both of those. Next slide. So the strongest predictor, as I mentioned, of CT imaging for pediatric patients depends on what kind of hospital you go to. And I understand the ease of getting a CT. It's very diagnostically certain. They're very fast and they're easy to get. The question that begs to be raised over and over again is it the right thing to do? Next slide. So the other system problems is that not all hospitals do dose adjustment for size and age. I can't tell you how many times kids have been imaged and they couldn't transfer the data. So there was lack of portability. We're blessed here in some respects by the ability to share and look at images that are done at the other hospitals in the ballot system. Occasionally people get non-contrast CT imaging for the reasons I told you. They don't have a creatinine back. They didn't want to give it to IV stuff to the kid. But I want you to know that non-contrast CT imaging for acute abdomen and trauma is a lot of radiation dosage. It's the same dosage of radiation without the utility clinically for us. The one indication for doing a non-contrast CT for an acute abdominal condition in a child is a stone protocol, and we don't deal with that very much. And children are 10 times more likely to get a CT at a referring hospital than they are at a children's hospital. Next slide. So assuming that there's 4.5 million pediatric CT scans each year, 4 million would be including head, abdomen, pelvis, or spine. If those scans parallel observed dose distributions, approximately 4,870 future cancers could be induced by pediatric CT scans every year. Next slide. And this is the study I showed you that Brad gave me that just hot off the presses, JAMA Surgery Network. And this was a very interesting study of over 1 million people, including 800,000 who had appendicitis in Korea. And they looked at mostly lymphomas and leukemias, and they found that the carcinogenic risks from abdominal pelvic CT radiation were most profound in patients aged 0 to 15 years. Next slide. So those are some of the references, which I hope if you want to look up would be helpful, including some of the ALERA data stuff that's been published. But I think this is it's a fertile area for us to think about. CT scans are easy to get, but in a child, children are much more radiosensitive, and the stochastic risks of ionizing radiation in a child are much more profound and lifelong than they are in somebody my age who gets a CT scan for belly pain.
Thanks, Michael. So, Michael, if I'm working in an ED and I'm unsure of a child's diagnosis, but I think it's an intra-abdominal process, what would you like me to, and I think I need an imaging study. How would you like me to proceed with that?
Well, I think if, for instance, if you have certain presentations like obstructions, plain films can be helpful. They're not always helpful with appendicitis, and ultrasound imaging is helpful. But I think if it's a complicated problem and you're going to need cross-sectional imaging, the safer of the two options would be MRI. But of course, magnetic resonance imaging is out there for appendicitis. It has to be done with a rapid protocol, and it has to be in collaboration with your imaging folks, because it's not easy to do an MRI in a 3-year-old without sedation or anesthesia coverage. And you have to do that sometimes if that's what you need. But I also think do the simple non-ionizing radiation imaging, and then talk to the pediatric surgeons and the pediatric ER doctors and let us help you decide what we're going to need to do. I think I've talked to a couple of the small ERs who've referred kids that did CT scans, and I asked them, what were they going to do with the image anyways? And they said, well, we're going to transfer them to you. And I said, well, then fine. That's a perfect kid to send to us anyways, and let us help with the imaging decisions.
Questions from the audience for Dr. Allshouse about imaging or anything else?
I mean, I want to leave people, I love CT scanning, and for certain things, tumors, Wilms tumors, neuroblastomas, certain types of bowel obstruction and things, it's helpful. But since we're talking about appendicitis today, I think the focal point here was to try to bring to people's attention that a CT scan for appendicitis might be best reserved for the kids who have really complicated cases like the ones Lesli was talking about, where we're involved, and should not be used as a routine screening exam for kids with belly pain that you think might have appendicitis. The first case I mentioned was a girl who's got such a myriad of chronic abdominal complaints that you can imagine she's going to get a lot of imaging in her lifetime. So whatever we can do to minimize her exposure as a child would behoove us to think about.
Thanks, Michael. See, we just have a couple minutes left. I wanted to present one final case, just to make one final point from am I sharing my screen now?
Yes.
Okay, thanks. Going back and forth, actually it's worked pretty well. So this is a, but now my slides aren't advancing. Okay, so this is, here we go. So this is a 14-year-old girl. So age makes a big difference for us because our differential diagnosis changes dramatically with adolescence. Okay, so of abdominal pain, and so age makes a big difference as far as what's at the top of our differential diagnosis. So this is a 14-year-old girl with 8 hours of right lower quadrant pain, and she's not hungry. Sudden onset. She told me exactly when it started. 9:42. She felt like she felt doubled over in pain. It was continuous. It was sharp. She didn't have any vomiting. So this is a classic in an adolescent female. This is the top of your diagnosis needs to be ovary. Okay, the ovarian pain starts suddenly, either from a torsion or a ruptured cyst. And so that's the first thing that I would think of for an adolescent girl. That this could be an atypical presentation. So 40% of pediatric appendicitis will have an atypical component to the presentation. Either the kids will be hungry, they won't have any anorexia, they won't have any vomiting. It'll be a weird initiation. So we always think of atypical because atypical presentation of appendicitis is fairly typical. But again, for an adolescent girl with a sudden onset of pain, I think ovarian until proven otherwise. She's mid-cycle on her menstrual cycle. Her right lower quadrant was tender. She was guarding. Her CRP was mildly elevated. Her white count was normal and no left shift. We got an ultrasound that did not demonstrate her appendix, but she had a lot of fluid in her pelvis. She had more fluid in her pelvis than we'd expect. So I suspected a ruptured appendicitis. She was still sore, requiring IV pain medicines. And on the ultrasound, we demonstrated that her ovary wasn't torsed and it had normal flow. So the following day, she still had a lot of pain, requiring IV pain medicine. So when that happens, I go ahead and put a camera in. I go ahead and put a camera in, and this is what we usually find. We find a lot of blood from a ruptured ovarian cyst, and they have this hematogenous ascites, and this can be really irritating to the peritoneum. So we aspirated that out. Her appendix looked normal, and she went home a few hours later. So this was the last case that I wanted to present, just as another thing to think about with pediatric abdominal pain. And the keys for this, if an adolescent female presents with a sudden onset of sharp abdominal pain, ovary really needs to be at the top of your list of your differential diagnosis. So with that, I think that brings us exactly to 1 o'clock. Thank everyone for participating. Dr. Chambers and her team have put together a fantastic monthly series this year for the ECHO series, and we're looking forward to seeing everyone on the next ECHO call. Patricia, are you still with us? She's probably delivering a keynote speech in Kingsport. Melissa, do you have any final comments or anything for the attendees?
The only thing I have is just to make sure that you do register on that. I know we've said that multiple times, but it's just important that you can get the notifications after this session and in the future. And then that will also help you create an account in Hallmarks to make sure that you get your credit for attending today's session.
Excellent. Okay, everyone have a great rest of your day. Thanks for sharing your lunch with us.
Thank you.